That takes us to page 209. And on 209, the topic is ventricular hypertrophy. And we wrote that like any other muscle, the heart hypertrophies. What does that mean, hypertrophy? Gets bigger. Hypertrophy, increased growth. So it hypertrophies in response to an increase in workload. If you lift heavier weights with your arm muscles hypertrophy. They get bigger and stronger. If your ventricles of your heart have to work harder, they get bigger and stronger. Having said that, we actually wrote, however, that there are two principal causes of the heart growing bigger. One of them is a good reason why your heart is getting bigger, and the other is a bad reason. Let's start with the good reason. Your heart, not surprisingly, will hypertrophy in response to aerobic or cardio exercise. Any exercise that causes your heart rate to speed up is known as aerobic exercise or a cardio workout. So the more you do Zumba, or I think that's what you were doing there. The more you do aerobic conditioning, running, treadmill, bicycling, swimming, that increases the workload on the heart, and the heart grows bigger and stronger. Marathon runners will have hearts 2 or 3 times larger than that of the rest of us. And that's considered great. That's fantastic.
They're nice people.
They're nice people. And incidentally, when they're not running, their hearts are so large and strong that their hearts are so big and strong that their hearts, when they're not running, only have to beat maybe 55, 60 beats a minute. And they can inject the same volume of blood that the rest of our hearts can inject by beating about 75 times a minute. So if you've ever seen somebody who's a fantastic athlete, don't be surprised to see these really slow heart rates, because they've got really big, strong hearts when they contract. Now, there's a bad reason why your heart may enlarge, and that's hypertrophy in response to high blood pressure, increased arterial blood pressure. Now, we wrote that whenever your arterial blood pressure, especially the diastolic blood pressure, increases, that increases the workload on the ventricle and causes the ventricle to enlarge. The term that cardiologists use for an elevated arterial diastolic blood pressure is afterload, and yes, I would like you to know that. Now, I want to have us make sure we understand why having high blood pressure, especially an elevated arterial diastolic blood pressure, makes your heart have to work harder. Now, we just said that normally the blood pressure in your aorta is about 120 over 75, 120 over 80. I'll say 75, but I could have written 80. Let's imagine, though, that for whatever reason, somebody's blood pressure, instead of being 120 over 75, what if the lowest that their blood pressure ever gets is 95? All right? We don't even care what the systolic is. What if the lowest that the blood pressure ever gets in their aorta is not a low of 75 or 80, but 95 or even 100? Can everybody see? I'm trying to show that the diastolic arterial blood pressure is higher than normal. So let's, we'll ask for the 3 gentlemen that worked before, so we'll have you do try something else again. All right? So remember, all right? All right, now remember, they represent the sheer brute strength of the left ventricle. All right, now let's just we'll do first time, you're just going to push against the door, and there's a pressure of 75 on the other side. So go ahead. All right, go ahead, push. Okay, good. All right, now, so that was easy, right? All right, now let's imagine that the lowest that the blood pressure ever gets on the other side is 95 rather than 75. All right, maybe even 100, okay? All right, so go ahead. Go ahead, push. Push. Incidentally, in case there's any guess, it was just me on the other side. Now, did you have harder.
Oh, yeah.
All right. I think he was dancing, but anyhow. Now the point is, the higher the diastolic blood pressure, the harder the left ventricle has to work to get the damn aortic valve open and begin to eject blood. Now what the heart does to compensate, if normally the ventricle, if it opens the aortic valve at 75, then it's able, by raising the pressure from 75 to 120, it's able to eject 70 milliliters of blood. So how much did it raise the blood pressure by? It opened the aortic valve at, let's say 75, and it increased it went from 75 to 120, so it raised it by what? 45 millimeters of mercury. 120 minus 75? Is that right? All right, so by raising the pressure from 75 to 120, it ejected 70 milliliters of blood. If now that the diastolic doesn't get any lower than 95, now you might say why? The most common reason why it's so high is all the clogging up of the arteries with fat. So that's raised the pressure inside our pipes. So now, if the left ventricle can't even start to eject blood until it gets over 95, it still has to raise the pressure by 45 millimeters of mercury to eject the same 70 milliliters of blood. Does everybody follow? So now, if the diastolic, because of atherosclerotic plaque, doesn't get lower than 95, the heart, to compensate, has to raise the pressure. What's 45 plus 95? 140, right? So it's got to raise the pressure up to 140 instead of 120. So the higher the diastolic gets from clogging up a plaque, the higher the systolic has to go to eject the same volume of blood. Do you follow that? So that's why some of you have heard that it's really the diastolic number that they look at. You ever heard of that? It's the diastolic, because the higher that diastolic is, because of, say, atherosclerosis, the higher the systolic will have to become to eject the same volume of blood as normal. Because it doesn't even get the damn valve open until it exceeds 95. What if somebody's blood pressure doesn't get any lower than 100? Then it's going to raise it to 145. What if it doesn't get any lower than 110? Then it's got to raise it up to 155 to eject the same volume of blood. So the systolic is really a response by the heart to compensate by the fact that it doesn't even begin to eject blood to a higher pressure. So with every ejection of blood by the heart, it's working harder than normal. Okay, now here's the final question. If exercising makes your heart work harder, and that's considered good, then why is having high blood pressure, which makes your heart work harder, considered bad? Yep.
Yeah, because you don't want it going on 24 hours a day.
Exactly. It's exactly what I wrote right here. If you exercise and you make your heart work harder for a half hour, for 45 minutes, for an hour, that's great. You made your heart work harder. Nothing wrong with that. Your heart gets bigger and stronger. And the other 23 hours of the day, okay, where you're not exercising, you've made your heart bigger and stronger. It is more than able to deal with that lower work levels the other 23 hours of the day. But if you've got high blood pressure, how many hours a day is your heart working harder? 24 hours a day, even when you're asleep. And that'll kill your heart. You'd say, why? So if we were going to force you to lift weights 24 hours a day with your arms, you'd say, you're going to kill me. Well, that's what you're doing to somebody's heart. You're making their heart work harder than normal 24 hours a day. You're going to kill your heart. It just can't work that hard 24 hours a day. Does everybody follow the difference? So again, this, the higher the pressure is in this aorta, the harder the left ventricle has to work to eject the blood against this higher than normal pressure. Again, it's probably largely due to a bunch of crud accumulating on the inside walls of the vessels, And the higher the diastolic, this is called an afterload. You should know that term. Afterload. It's all written here. It's also in your book. Now, that takes us to 210. And on 210, let's analyze cardiac output. Now, we had originally defined cardiac output right at the beginning, around page 168. A cardiac output is simply the volume of blood ejected by each ventricle per minute. Now, we had learned that the normal cardiac output is about 5 liters per minute at rest. You'd say, when did you ever tell us that? Page 168. You can look. The cardiac output is primarily determined by heart rate times stroke volume. What's the normal heart rate at rest? Oh, about 70, 75 beats per minute. And how much blood does each ventricle eject with every stroke of my heart? 70 milliliters of blood is ejected with each stroke, with each beat. So, if we multiply 75 beats per minute times 70 milliliters of blood ejected with each beat or contraction, the beats cancel out. It's got no beat, no rhythm. No, but, and you get 70 times 75, or 5,250 milliliters per minute, which is 5.25 liters per minute. So it's about 5 liters per minute. Incidentally, if I were to give you heart rate and stroke volume, could you calculate cardiac output? What if I gave you cardiac output and heart rate? Could you give me average stroke volume?
Yes.
All right, because if you know any two, you could solve for the third. Okay, that's how all these things work. Now, during exercise, what happens to your heart rate? It speeds up. And we're also going to see during exercise, the stroke volume increases. So if the heart rate increases and the stroke volume increases, no wonder your cardiac output increases. Maximal, in terms of cardiac output, in marathon runners, it may double or triple to 10 or even 15 liters per minute. So from the 5 liters per minute, in fact, there's even some marathon runners, they've even measured, they have reached maximum cardiac outputs of up to 25 liters per minute. All right, because they've got huge, massive hearts. Obviously, that's what allows them to run at an extremely rapid rate for over 26 miles without stopping. I can't do that, but they can. So here we've just summarized that cardiac output is heart rate times stroke volume. Let's summarize what a normal heart rate is. A normal heart rate at rest is about 70, 75 beats a minute. What's the normal range? 60 to 100. Have we ever learned that before? Yes, a number of pages ago, because we had said that the definition of bradycardia is a heart rate slower than 60 at rest, and a definition of tachycardia is a heart rate faster than 100 at rest. At rest. We all develop tachycardia during exercise, but you shouldn't have a heart rate faster than 100 beats a minute if you're just sitting in a chair. Now, what about maximal heart rate? We've said that for people in their 20s, maximal heart rate is about 160, 165 beats a minute, right? And that's really what your target is in your 20s to get about a heart rate of about 160, 165 beats a minute. 80% of its theoretical maximum. We don't really want to go much beyond that. What controls your heart rate are autonomic motor neurons to the heart. Parasympathetic slow it down, sympathetic speed it up. Okay, now what about stroke volume? Stroke volume. What's the definition of stroke volume? That's the volume of blood ejected with every stroke of my heart, with every beat, which is normally about 70 milliliters at rest. Now, stroke volume is determined by myocardial contractility. Is that a new term? No. We learned it back on page 105. That's the force of contraction. So your heart not only can increase or decrease its rate, it can also increase or decrease the force of contraction. And the more forcefully it contracts, the greater the stroke volume. Now we know that sympathetics epinephrine, norepinephrine, sympathomimetic drugs make not only your heart speed up in terms of speed, but also increase myocardial contractility, increasing stroke volume. But there's another thing that can increase myocardial contractility, and it's known as Starling's law of the heart. Starling's law of the heart. And what's that? So let's look at the next page, 211. And on 211, now this concept that I hand wrote at the top of 211 is another concept that, had we covered skeletal muscle physiology, I actually present in the skeletal muscle physiology section. I'll just read it. It says, a stretched muscle contracts more forcefully than a non-stretched muscle. Basically, muscles behave a little bit like rubber bands. You know a rubber band? If you have a muscle and you don't stretch it and you stimulate it to contract, it'll contract. If you stretch the muscle and now make it contracts more forcefully, like a rubber band, right? So the more you stretch it, assuming you don't overstretch it, the more you stretch it, the more powerfully it contracts. All muscles do that. Skeletal muscle, and so does heart muscle. In the heart, they call it Starling's law of the heart. It's also known as the length-tension relationship. So here's what we wrote. Any change in the end diastolic volume, which cardiologists call the preload, which is the filling of the ventricle, causes a change in myocardial stretch, which causes a change in myocardial contractility, which causes a change in stroke volume. Let's go back a step, because you're probably thinking, what? Imagine you had a balloon, and you filled the balloon with water. The more water you fill the balloon with, what's that water? As you fill the balloon with more and more water, what's it doing to the wall of the balloon? It's stretching it. So as the ventricle fills with more and more blood, and what do we call the volume of blood that fills up the ventricle during diastole? The end diastolic volume. So as the end diastolic volume increases, as you fill the ventricle with more and more blood, it is stretching the wall of the ventricle, just like filling a balloon with more and more water. And didn't we just say that if you stretch a muscle, the more you stretch it, the more powerfully and forcefully it contracts. So the more blood that fills up the ventricle, the more you stretch that wall, and the more forcefully it contracts, which is called increased myocardial contractility. So increasing the filling of the ventricle with blood, known as end diastolic volume or preload, stretches the ventricle wall more, which causes it to contract more powerfully, which causes it to increase the stroke volume. Now, the best way to show you this is in the form of a graph. Right? We're getting so good at graphs. All right, what does it show on the x-axis? The end diastolic volume. You'd say, I forgot what that means. That means how much blood has filled up the ventricle when it's during the filling time. What's shown on the y-axis is the stroke volume. You'd say, what's that? That's how much blood is ejected. So let's start with this solid black line labeled normal heart. And what it's showing is that as there's more and more blood filling the ventricle, it ejects more and more blood. So as more blood, remember how we always describe a graph as the, and we look at the x-axis. As the end diastolic volume increases, the stroke volume increases. The more blood that fills the ventricle, the more forcefully it contracts, and the more blood it ejects. Let's see that. If the ventricle fills with, let's say, 150 milliliters of blood, right? If I drew a line to this solid line here labeled normal heart, it's ejecting about, I don't know, out of 150, it fills with 150, it ejects, I don't know, 90. according to this graph. If it filled with 200, it looks like it ejects about 150. Does everybody see that? Typically, it will eject about 2/3 of what's inside it. The more it fills, the more it stretches the wall of the heart, and the more powerfully it contracts and ejects more. So it does exactly what you'd want it to do. When the ventricle fills with more blood, it proportionately ejects more blood. Because the more you fill it, it stretches the wall more, and it contracts more powerfully to eject proportionately more. So it's not like the ventricle always ejects the same volume. It depends on how much is in it. That affects how much it ejects. The more it fills, the more it ejects. That's called Starling's law of the heart. Now, let's see what a sympathomimetic drug does, like epinephrine. We have learned that epinephrine not only increases the heart rate, but it increases myocardial contractility, the force of contraction. So in this, let's use the example that the ventricle, we said if the ventricle fills with 200, a normal heart will eject about 150. What if we gave somebody adrenaline and now measured how much blood did it eject? If it fills with 200 and we've given the person adrenaline, can everybody see it? Looks like it's ejecting all 200. It's contracting more powerfully. So epinephrine not only makes the heart beat faster, it makes the heart contract more forcefully. And it ejects proportionally more than normal. So that's increasing cardiac output. Now, let's look at this graph line labeled failing heart. Now, failing heart is a sick heart, a weak heart. It's dying, it's weak. Let's imagine the ventricle filled with 200 milliliters of blood. In this very weak heart, how much does it show it being ejected? About 50. Can everybody see that's less than normal? A normal ventricle would have ejected 100. So it's ejecting less than normal. It's contracting more weakly, less powerfully, and even though it's still filling with 200, it's ejecting less than normal. Now, many years ago in the 1940s, cardiologists figured, hey, we know how to deal with a failing heart. We've just said that adrenaline and other sympathomimetic drugs make the heart contract more forcefully. So let's give somebody who has a weak, failing heart adrenaline. Let's see what it does. So here it's labeled failing heart with sympathetic stimulation. The ventricle fills with 200. In the weak heart, it would have ejected 50. Giving them adrenaline makes the heart contract more forcefully, and it ejects 100. Is that improved? Yes. Is it normal? No, it's still less than normal. It should have, a normal heart would have ejected 150, but at least it's better. There's one problem though. You'd say, yeah, what's the problem? If you've got a weak, sick heart, you don't want it beating faster than normal. And epinephrine, unfortunately, while it will make the heart contract more forcefully, which you would like, unfortunately, it's also simultaneously going to make the heart rate speed up and go faster, which is going to put an undue burden or strain on that weak heart. So think about this. What we really need is we need a drug that can increase the force of contraction, like epinephrine, without making the heart rate speed up. Is there such a drug that would increase myocardial contractility, like epinephrine, but not cause tachycardia?
Yes.
Yes, there is a drug, or I wouldn't have mentioned it. And the name of the drug is on page 213. On the top of 213, the name of the drug is Digitalis. Has anybody ever heard of Digitalis? So Digitalis, or digoxin, is given to people with failing hearts. That's one of its uses, one of its most important uses. It increases myocardial contractility, like epinephrine does, but in fact, it actually slows down the heart rate, causing bradycardia. Epinephrine causes tachycardia. So giving somebody Digitalis, which is what they do, makes their heart become like this. It makes the heart contract more powerfully, increasing stroke volume without speeding up the heart rate. In fact, it actually tends to slow the heart rate down. So the point that I'm really trying to make is the following. Not only do you need to learn all this terminology to understand the physiology of the heart, when you take your courses in pharmacology, you're going to be learning that some drugs cause increased myocardial contractility as well as tachycardia, such as sympathomimetics. And then you're going to learn there's drugs like Digitalis, which increase myocardial contractility, but in fact cause bradycardia. And there are all kinds of other variations. But the way we describe the effects of the drugs on the heart is by using these cardiological terms that we've introduced you to. All right, we'll have more to say about Digitalis yet. On page 212, now we've just been learning that the more that the ventricle fills up with blood, the more powerfully it contracts and ejects more blood. That's called Starling's law of the heart. But our next question is on 212, fine, but what would increase or decrease the amount of blood that your ventricle fills up with? Why would the volume of blood that your ventricle fills up with change? In fact, there are many things, many factors that can affect the filling of the ventricle with blood. I'm going to give you two. One thing that affects the filling of the ventricle with blood is the heart rate. Because we have already learned that when your heart rate gets faster and faster and faster and faster and faster and faster, the diastole, the time during which the ventricle has to relax and fill with blood, gets disproportionately short. So this is why when your heart rate gets really fast, especially faster than about 160 beats a minute, the filling time for diastole is so short that it fills with almost no blood. Not only does that mean that it's not filling with much blood, if it fills with less blood, it stretches the wall of the ventricle very little and it ejects very weakly. Right? Because the more it fills, the more powerfully it contracts and ejects more. So it starts to eject less and less, even though your heart rate's getting faster and faster. Another factor, even more important, is something called venous return. VR, not virtual reality, but venous return. Venous return is the flow of blood through the systemic veins back to the heart. And there are various things that can increase the flow of blood through our systemic veins back to our heart, and things that can decrease this venous return, this flow of blood back to our heart. As a visual, and we're going to see this picture in a little bit, so don't worry about drawing it. I'm going to show it to you. This is just showing a water faucet. This is my own model. Okay, I invented this thing. This is a recycling system, right? Because whatever blood is ejected by your heart comes right back to your heart. Right? It's like a recycling system. This flow of blood back to your heart is called venous return. It's just the flow of blood in the veins back to the heart. And this is pictures on 215. You've got the exact same picture on page 215. 215. And so, imagine, if you want to look on page 215, you can. Some people want to draw it, so just say you don't have to draw it. 215. So imagine, what if you cut yourself and the blood is gushing out right here. It's coming out of a vein in your leg, let's say. Oh, no. What has that done to the return of blood back to your heart? It's becoming less. And since this is a recycling system, if there's less blood coming back to your heart, there's less blood for the heart to eject. It can't come from nowhere. So hemorrhaging, bleeding, reduces venous return. The ventricle fills with less blood, and therefore it contracts less forcefully and ejects less blood. So that's going to affect the cardiac output. It's going to affect the amount of blood it ejects. All right, so back where we were on page 212, that's what we wrote. Consider hemorrhaging. When somebody is hemorrhaging, what does hemorrhaging mean? Bleeding. That reduces venous return and therefore reduces filling of the ventricle with blood. Now, let's summarize all this junk that we've covered so far by looking at page 214, the last page that will be included for the third exam. Okay, we're now going to summarize some of the major factors that affect or determine cardiac output. And you can see in this diagram, this flow chart, let's start at the very bottom. At the very bottom of the flow chart, it indicates cardiac output. And of course, as we have already learned, cardiac output is determined by two major factors, heart rate and stroke volume. And so whether we write it out this way or whether we show it in the form of a flow chart, that the heart rate and the stroke volume determine the cardiac output. Let's first examine what affects heart rate, and then we'll look at what affects stroke volume. The major factor that affects how fast your heart is beating, the heart rate, you'll notice I have only one arrow pointing downwards to heart rate. Let's follow that arrow from where it originated, and it says autonomic motor neurons. So autonomic motor neurons are the major factor that affect how fast our heart is beating. Parasympathetics slow the rate down. Sympathetics speed the heart rate up. Okay, so much for heart rate. Now let's look at stroke volume. What is stroke volume? Stroke volume is the volume of blood ejected with every beat or every stroke of my heart. And normally it's about 70 milliliters per stroke or per beat from each ventricle at rest. Now we show two arrows pointing to stroke volume. One of them is a solid arrow, the other is a dashed arrow. Let's start with the dashed arrow. The dashed arrow is indicating that this is an inverse relationship. And it shows, it's labeled arterial blood pressure or afterload. The greater the arterial blood pressure, the less the stroke volume. And this is what we spoke of earlier. We said that the higher your diastolic blood pressure, the greater that the pressure is in your arteries, the greater the force that your ventricles have to generate to eject any blood. So in general, in fact, as your blood pressure rises higher and higher and higher, greater than normal, your ventricle will progressively eject less and less blood. There's a decrease in the stroke volume and how much is ejected because it simply has to work harder to eject that blood, and it may not be able to do it. So that's an inverse or negative relationship. A positive relationship, something that will increase stroke volume rather than reduce it, is the myocardial contractility. What is myocardial contractility? That is the force of contraction, how forcefully the ventricles contract. Now we actually show two arrows pointing to myocardial contractility. The top arrow is coming from where it says autonomic motor neurons. Because after all, we have learned that sympathetic autonomic motor neurons and adrenaline, epinephrine, increase myocardial contractility. And by making the heart contract more forcefully, that increases stroke volume, the amount of blood that's ejected. But there's a second factor that we've learned that also affects myocardial contractility, known as Starling's law of the heart. Starling's law of the heart is the relationship between the end diastolic volume and the force of contraction. By end diastolic volume, we mean the filling of the ventricle with blood. We have learned that just like filling a balloon stretches the wall of the balloon, filling the ventricle with more blood stretches the wall of the ventricle, and it, just like a stretched rubber band, it contracts more forcefully, and that increases the stroke volume. So the filling of the ventricle. Now, what can affect filling of the ventricle, the end diastolic volume? There are really many factors, but we show two of these many factors here with these two arrows. One factor that affects the end diastolic volume is the heart rate. We have learned that as the heart rate gets faster and faster and faster, the filling time, the time in which the ventricle has to fill with blood, becomes progressively a shorter and shorter time. So that's why, again, we have a dashed arrow and a minus sign. As the heart rate increases, the filling time decreases. And as the filling time, the greater the filling time, the greater the end diastolic volume or filling of the ventricle with blood, the shorter the filling time, the less the end diastolic volume or filling of the ventricle with blood. Another factor that can affect the end diastolic volume, the filling of the ventricle with blood, is venous return. We've learned that venous return, VR, refers to the return of blood through the big veins of the body, the superior and inferior vena cava, of that flow of blood back to the heart. And what can affect how much blood flows back to the heart, the venous return, filling the ventricle with more blood, is the degree of Vino Constriction. Now, what is Vino Constriction? That refers to constriction of the veins. So constriction of arteries or arterioles is called vasoconstriction, but constriction of veins is called venoconstriction. And when the veins constrict, it actually squeezes more blood back to the heart, increasing venous return and increasing end diastolic volume. And what controls the degree of constriction or dilation of the veins is, again, autonomic motor neurons. Sympathetic autonomic motor neurons not only tend to cause blood vessels, arteries and arterioles to constrict, but also tend to cause veins to constrict, the sympathetics and the action of adrenaline. Now, some of us might be thinking, wait a second, why would constricting a vein increase the flow of blood, the venous return of blood back to the heart? Wouldn't constricting a vein reduce it? Let me remind you that veins, unlike arteries, have valves inside the veins. You learn that in anatomy. So if a vein is going to constrict or squeeze, that does not cause the blood to flow backwards. That simply means that less blood can accumulate in those veins, and as the veins constrict or squeeze, it actually squeezes the blood, increasing the flow of blood back to the heart, increasing venous return. The valves prevent the blood from flowing backwards. All right, so in summarizing this flow chart, let's try to throw all this jargon together in kind of one fell swoop. We could imagine the following discussion occurring about a patient. We could imagine the following discussion that a patient, perhaps, who is hemorrhaging or bleeding, because they are bleeding, there is a reduction in their venous return or flow of blood back to the heart. This decrease in venous return is resulting in a decreased end diastolic volume or filling of the ventricle with blood. Because of Starling's law, if the ventricle fills with less blood, it contracts less forcefully. And if it contracts less forcefully, which is known as a decrease in myocardial contractility, that will cause a decreased stroke volume. Any decrease in stroke volume will result in all probability in a reduction or decrease in cardiac output. Similarly, we could use this diagram to point out that any increased arterial blood pressure, increased blood pressure in the arteries, would result in a decreased stroke volume, and again, any decrease in stroke volume would be accompanied by, in all probability, a decreased cardiac output. So this is the vocabulary or jargon that is used by cardiologists. If we return back to page 213, page 212, page 212. So on page 212, page 212, let's look at some clinical applications of what we've just learned. There are two types of heart failure. Either it's the right pump that's failing or the left pump. We have learned that the more common pump that tends to fail is the left one because it works 6 times harder than the right. The definition of heart failure, congestive heart failure, which means a weak heart, the definition is a decreased cardiac output. So if the cardiac output is less than normal, we would say that pump is failing. If it's the left pump that's failing, that results in a decreased cardiac output through the systemic circuit, through the aorta and the systemic vessels of the body. If it's the right pump that's failing, that results in a decreased cardiac output through the pulmonary circuit, through the pulmonary arteries and the pulmonary circuit of the vessels of the body. Is it possible for somebody to have both left-sided and right-sided failure at the same time? Of course it is. And therefore, they could have both a decreased systemic cardiac output and a decreased pulmonary cardiac output. Now, what I've written at the bottom is the etiology, which means the cause of the failing heart. So what I've tried to do is I've tried to take about 2,000 pages of information that would be found in a book on cardiology and cardiovascular physiology and distill it down to one line. Obviously, this is a gross oversimplification. But this is basically, in a simplified form, the explanation of cardiovascular disease. It's a domino effect. It begins with atherosclerosis, and as that progresses, it leads to high blood pressure. As that progresses, the increasing high blood pressure, that increases the workload on the heart, and eventually, this increased workload on the heart cannot keep up with this increased workload. It starts to eject less blood, that's called a decreased stroke volume. The cardiac output drops, and by definition, a decreased cardiac output is called heart failure. So, what doctors try to do, in a nutshell, is to catch this as early on in this sequence as possible, to basically prevent further progression of this degeneration of the cardiovascular system. So, since we know that this buildup of fatty plaque, called atherosclerosis on the inner walls of our blood vessels, is related to our cholesterol levels, or at least that's the general consensus. That's why when they see an elevation in cholesterol level, they put the person on Lipitor. The hope is by lowering the cholesterol level that will reduce, or at least prevent further increasing buildup of atherosclerotic plaque on the walls of the arteries. We know that as this crud builds up on the inner walls of the arteries, it's believed that that's the principal cause of high blood pressure, what's called essential hypertension. And if some people have already developed high blood pressure, that means that they have to put them on antihypertensive medication as well as Lipitor to prevent further buildup of atherosclerotic plaque. The two most common categories of antihypertensive medication would be beta blockers, sympatholytic drugs that block adrenergic receptor sites on the heart and vessels of the body, and diuretics, including ACE inhibitors, or drugs that interfere with the renin-angiotensin-aldosterone reflex to try to reduce blood volume and blood pressure that way. Let me also remind you that atherosclerosis not only increases the probability of high blood pressure due to clogging up of the arteries, but it also increases the risk of blood clots forming in the vessels, so the patient may also be placed on, quote, blood thinners or anticoagulants, including the baby aspirin or Plavix or other drugs, even Coumadin, to prevent blood clots from forming, which are the principal cause of heart attacks and strokes. If the progression of the disease has already reached the point where the heart is failing, we have learned that the medication that they give to people to increase myocardial contractility and cause the heart to contract more forcefully to increase cardiac output is a drug called Digitalis or digoxin. And so if somebody has reached this state where they already have a failing heart, that means they're on Digitalis to increase cardiac output. They're on antihypertensive medications, including possibly both diuretics and beta blockers. And of course, they're still taking drugs to lower their fat and cholesterol levels to prevent this disease from even becoming worse. So that's kind of it in a nutshell. You'll notice that on page 213, this is showing basically congestive heart failure. If we start out where it has number 1, right here, so it simply says high pressure in the systemic circulation, increased blood pressure in the systemic circuit, strains the left ventricle to the point of failure. As we've said, high blood pressure makes the ventricle have to work harder to eject blood out. Number 2, failure of the left ventricle causes, quote, congestion of blood in the pulmonary veins. The blood starts to back up into the blood because the high pressure in the left ventricle, the high pressure in the systemic circuit is causing a reduction of the ejection of blood by the left ventricle. The blood is backing up into the left atrium. It is backing up into the pulmonary veins. It is backing up into the pulmonary capillaries. And we can see that as the blood backs up into the pulmonary capillaries, this increases filtration of pressure, the filtration pressure of fluid out of the pulmonary capillaries, resulting in pulmonary edema, as we've spoken of before, as there's increased fluid squirting out, and that leads to pulmonary edema, as is written right here. And of course, as we've said, by taking a drug like Digitalis, digoxin, that increases myocardial contractility, the force of contraction. And the idea is if the ventricle can be caused to contract more forcefully, it will start to eject the blood forward, increasing cardiac output through the systemic circuit and helping to reduce this backup of blood in the pulmonary circuit, reducing pulmonary edema and difficulty in breathing. Now, as we move on to the next topic on page 215, we want to focus on page 215 on blood flow, especially through the systemic circuit. And there are many ways of depicting how blood flows through the systemic circuit. In this diagram, it reminds us that the left pump pumps the blood out into the aorta, through the systemic vessels, and the blood comes back to the right pump. And of course, the job of the right pump is to pump blood through the lungs. Another diagram, another way of representing this is here it represents the heart and the lungs as the pump oxygenator unit. And if that sounds a little weird, in fact, there is a machine that basically does the job of the heart and the lungs. It's called a heart-lung machine that a patient is placed on during open heart surgery. And basically what the pump oxygenator then does is it oxygenates the blood and pumps the blood through the systemic circuit. First through the arteries, then the capillaries, and then it comes back to the veins of the body. But then there's an even more famous way of depicting the flow of blood through the systemic circuit, and that's my very famous, and maybe not so famous, water faucet model. And this is the model that I've come up with for trying to depict and describe how blood flows through the systemic circuit. Basically, we know that it's a recycling system. The blood that is ejected out by the heart into the aorta goes through the systemic circuit, and it returns right back eventually to that same water faucet, as it were. So however much blood is coming out, the amount of blood that returns back, and we know that the term for the return of blood back to the heart is called venous return. How much blood is coming back, or the venous return, will ultimately affect how much can then be ejected out, which is called cardiac output, because it's a recycling system. Now, there is a formula for relating flow, pressure, and resistance in describing the flow of fluids in any system of pipes. The amount of flow depends upon the pressure. It is directly proportional to the pressure and inversely proportional to the resistance, or whatever hinders the flow of fluid through those pipes. Now, to take those same terms, water flow, water pressure, and resistance to water flow, to turn them into more cardiovascular terms, the term that we use for the flow of blood, the amount of blood flowing through our pipes or our vessels per minute, is cardiac output. And the term for pressure is blood pressure. And the term for resistance, we'll just use resistance for the moment, but we'll get to the technical term in just a moment. Now, in fact, we can rearrange these three terms. We know that if we know any two of these terms, we can solve for the third. So rearranging these terms, as you can see at the bottom, at the very bottom, we can rearrange them so that pressure is equal to flow times resistance, or using our cardiovascular terminology, the arterial blood pressure, and to be more precise, the average or mean means average, the mean or average arterial blood pressure is equal to the cardiac output, which we know refers to blood flow, multiplied times the TPR. TPR stands for total peripheral resistance. And what TPR is whatever factors that hinder the flow of blood through the pipes or vessels of the body. So we're going to be referring to this formula, this relationship, as we go on.